I'm Dr. Carmen Puliafito, and I'm happy to be here today with Dr. Mark Barakat, who is director of the Retinal Research Institute at Retina Consultants of Arizona, an assistant clinical professor at the University of Arizona, Phoenix Medical School. Mark, welcome back to Retina Synthesis.
Thanks for having me. It's a pleasure to be here.
So today we're going to talk about suprachoroidal therapy of neovascular AMD. Can you give us an overview?
Absolutely, happy to. So as I'm sure we all know, a suprachoroidal approach is very attractive because it's compartmentalized and it's localized to the posterior segment where we want to treat the disease state. And so there's 2 trials currently ongoing that are looking for a suprachoroidal approach in the treatment of neovascular AMD. One of them is Clearsight's trial called OASIS, and the other one would be REGENXBIO's trial called AVIATE. With OASIS, it is looking at axitinib, which is a tyrosine kinase inhibitor. Tyrosine kinase inhibitors inhibit VEGF receptors 1, 2, and 3. So basically a pan-VEGF inhibition intracellularly, and axitinib is actually a very potent version of a tyrosine kinase inhibitor. And what this trial was an open label dose escalating trial with a 1 suprachoroidal injection of very treatment experienced patients. That was followed up for 3 months, and then with a further extension to 6 months. And we talked a little bit about the 6-month data. So as mentioned, these are treatment experienced patients. On an annualized basis, they were getting about 8 to 12 or so anti-VEGF injections prior to the trial. And what was noted that the safety profile was excellent. There were no serious adverse events and there was no concerns with inflammation. And additionally, in terms of the secondary endpoints, the efficacy was quite encouraging. So over 90% went greater than 3 months without needing any further treatment. And 2/3 of patients actually went 6 months or longer without needing any treatment in the later cohorts. So cohorts 3 and 4, as I mentioned, it was a dose escalating trial. So with that sort of treatment pattern, there was actually a reduction of somewhere between 77 and 85% or so in terms of treatment burden. And so this is very encouraging. And so that's why they announced a new trial, a phase 2b trial called Odyssey. This will actually not be an open label dose escalating. This will actually be in comparison. So there will actually be a faricimab arm as a control on label, of course, for loading doses monthly, and then continued on label treatment, versus the treatment arm will also have faricimab, in addition to which at the 3rd monthly loading dose of faricimab, they will get CLS-AX, the suprachoroidal injection of axitinib. And so we'll be very interested to see where that goes in terms of treatment reduction and stability. So that was the axitinib, the tyrosine kinase approach for the suprachoroidal space. With REGENXBIO's AVIATE trial, also suprachoroidal, of course. Their agent is RGX-314, which is an AAV8 vector that's targeted towards the RPE cells, and that expresses an anti-VEGF agent. It's already been in trials for subretinal surgical approach, and this will be suprachoroidal approach also for very treatment experienced patients that on an annualized basis we're getting about 8, 9, 10 injections or so. Open label, dose escalating. So doses 1, 2, and 3, whether they're neutralizing antibody positive or negative, those are also included. Interestingly, when we think gene therapy, we always worry a little bit about inflammation, as we all should. This trial is actually done without prophylactic steroids. So that's an interesting side note that to really pay attention to, because when you look at the safety data so far does show some challenges, but also a lot of promise. And so there was some intraocular inflammation with this approach across 4 cohorts, about 23%. Although most of it was mild to moderate, most of it was just anterior-chamber cells controlled with topical therapy. There were some cases of episcleritis, approximately 10% or so, also controlled with topical therapy or oral NSAIDs. So safety profile that showed an inflammatory risk, as with all gene therapy, but controllable. The more important overarching, I guess, takeaway from this, though, was the reduction in treatment burden in these patients, pre versus post treatment with RGX-314. And that reduction ranged anywhere from 63% to 85% across different cohorts. And so that was obviously very significant. And with that, with stable vision and a nice OCT response as well. So you're not getting this stability at the cost of vision, at the cost of anatomy. You're getting a nice treatment reduction. And given the combination of the mild inflammatory signal, but the signal that you could have a nice treatment burden reduction, they announced it in additional cohort. So we talked about cohorts 1 through 4 through 5, and now the additional cohort 6, will actually be both a NAB neutralizing antibody positive and negative patients, but in the presence of prophylactic ocular steroids. So can we have the best of both worlds, right? Can we reduce the inflammation even further, or rather preempt it, and still get that nice reduction? So in essence, what we have is 2 trials, 2 different compounds, but same approach in terms of injecting into the suprachoroidal space. With CLS-AX, with Clearsight, you have an 85% reduction in annualized injection rate. Sorry, it was 77 to 85. You have 67% injection free at month 6, and thus we have a new trial coming up. With RGX-314, you also have an 85% reduction in annualized injection rate, 67% injection free, and new cohorts coming up. So slightly different agents, same anatomic area that we're targeting, both showing a lot of promise in terms of reducing injection burden.
That's very exciting. The difference, of course, is that in the case of the TKI inhibitor, we're assuming that we'll need to deliver the drug more than once. And in the case of the gene therapy, it'd be a lifetime approach, correct?
Yeah, I mean, exactly, that's the hope. The hope with gene therapy is that, you always hesitate to say one and done, but I mean, that possibility is there. That is why once we figure out this little inflammatory piece, it's very exciting.
What's the prophylactic steroid that they're going to use?
So right now, the prophylactic steroid they're using is subtenon triamcinolone. Mm-hmm. That's one of the approaches.
So to speculate on how the TKI approach would work is we'd lock in a treatment effect from an agent like Eylea or Vabysmo, and then treat with the TKI to lock the treatment effect in?
I mean, obviously, both of us are speculating here, but yes, I mean, so far, it seems that with tyrosine kinase inhibitors, you get a nice durability effect. But it doesn't seem as if the onset is as rapid or as potent as some of the anti-VEGF agents. So chances are, the loading dose makes perfect sense. But for either one of these agents, I think, and this includes gene therapy, of course, it's less about never needing any other supplementary treatment. It's just more, to me, it's more of a question of, can we reduce the number of times these patients need to come in and be seen, perhaps, or the number of times they need to be treated? But I don't think it would really account as a treatment failure if you have patients going from needing 10 injections a year to needing 1 or 2 or 3.
Mm-hmm. What's the study design of the phase 3 trial for the gene therapy?
So the phase 3 trial for gene therapy hasn't been announced yet. So your guess is as good as mine. Right now, for the gene therapy for RGX-314, their parallel phase 3 trials are ongoing for the subretinal approach, the surgical approach. Same agent, injected after vitrectomy underneath the retina, obviating the concern for inflammation as is in a protected space.
Well, Mark, this has been a terrifically concise and precise review of these complicated areas. What do you see in the future?
Well, I mean, That's an open-ended question. What I see in the future, I think there's a lot of interest in tyrosine kinase inhibitors in general, not just in the suprachoroidal space. So it will be interesting to see how quickly that can get up and running and hopefully translate to a clinical product. In terms of gene therapy, I think we are still a little bit further out in terms of working out some of the logistics behind it. But in a perfect world, if we can get any delivery of gene therapy across the finish line, subretinal, suprachoroidal, intravitreal, you name it, I think that opens the floodgates, because then you can decide, well, what transgene product are we really looking for? What's the optimal place? Are we going to limit ourselves to wet AMD? I highly doubt it, right? So another thing that we can look at is dry macular degeneration, dry AMD, where there are less biomarkers that will help us, treat and extend. There's no treat and extend for geographic atrophy. That may be a more attractive target still. So future's exciting.
Great. Thanks a lot for your help with retina synthesis. Thank you.
Thanks so much for having me.